This on the screen. And
nice.
Slide and all that.
Thank you. Is the microphone up? Do I need the microphone? Hello? 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 Excellent. Hi, everyone. Thank you so much to everyone who came today. I think it's amazing. Is this microphone's working, yeah? Yeah. I think it's really good that you turned up in person. It's generally better. Also, the microphone feels good, but it's exciting. So today we're doing pediatric cardiology, and at the end we're doing a little bit of respiratory, but the focus is on cardiology with the focus on congenital heart defects. Who here has done Peds already? Who here is on Peds? Who here feels like they know pediatric congenital heart defects really well? Yeah? All right, cool. So for anyone who has ever been to any of my tutes before, and like some of you have, I have a little bit of an unorthodox way of doing them in that I try to make it a little bit more interesting and engaging. So kind of enough content to pass the exam, but not excessive content, like, you know, just as much as you need, but also kind of funny mnemonics and ways to remember them, because or else I feel like there's absolutely no way to remember this stuff because it is really boring. Please ask me questions throughout. I would appreciate any questions. I might not be able to answer them. Also, I'm going to be a bit of a dick and like call on people in the audience all the time, but I promise it'll be worth your while. So just kind of bear in mind that will happen. Okay, cool. So let's start off with this picture of the heart, kind of. Clearly I do this by hand. But if we're thinking about a normal adult heart, yeah, we normally, I mean, you know how it normally goes through. You go down the vena cava, you go to the right atrium, the right ventricle, through the pulmonary artery to the lungs. It gets all oxygenated, goes back to the left atrium, goes to the left ventricle, and then out through the aorta. Yeah, cool. That's like a normal human adult heart. But then when we're talking about fetal hearts, we've got two extra little things. So we've got the foramen ovale, which is between the right atrium and the left atrium. And we've got the ductus arteriosus, which is between the pulmonary artery and the aorta. Yeah. So what happens to a little fetus? So the little fetus has three different ways that it can get blood. Cool. So you're talking about from the right atrium all the way to aorta. There are three different ways. So way number one is like the normal adult way. So it's like still like kind of trickling through that normal adult way, kind of like practicing. Number two is that it goes from, maybe can I go like this? Will that work if I go like that? Ah, it does. That's good. So it goes from the right atrium, shoots its way to the foramen ovale, goes down and then through the aorta. Yeah, and that's way number two. And way number three, it goes down here. So like the right atrium, the right ventricle, to the pulmonary artery, and then instead of going to the lungs, it bypasses the lungs, bypasses the left heart, goes straight through the ductus arteriosus, through the aorta. Cool. Does that make sense? Yeah, for sure. Cool. So the other reason that's happening is in the little fetus, they're getting all their oxygen supply, all their blood supply through the placenta, right? And the placenta is feeding like a ton of blood into the right atrium. So the right atrial pressure is like huge, really, really, really big, way bigger than an adult. So then when they kind of become alive, i.e. they get born, what happens, is you've got, I'll do this again, you've got them taking a really big breath of air. So all of a sudden their lungs need a lot of blood and need a lot of oxygen, yeah? That's number one. And number two is that the placenta gets cut off. So what happens simultaneously, the pressure in the right atrium goes down because the placenta is being cut off. And because the lungs are being used, the left atrial pressure increases, yeah? So you get this shift, and the little foramen ovale goes like and like closes like a door because of that pressure difference. Cool. Yeah, you with me? And that happens within the first few breaths of life, and also like when you snip off the placenta as well. The ductus arteriosus, on the other hand, closes within the first few hours to days, so it takes a little bit longer to stay open. And that is for a few reasons. One, it's because it doesn't have that pressure difference kind of slamming it shut, but also it's just like slowly working. And on top of that, the placenta, because the placenta is, I guess, releasing a lot of factors to keep it open, the placenta leaves and then it slowly takes time to close. Yeah? As we can see, this is kind of relevant because later on we're going to talk about defects that happen with the ductus arteriosus that will happen only a few hours to days, not immediately. Yeah. And the last thing here is the VSD, and you're just like never meant to have a VSD. That's just like an issue. Cool. So general principles of congenital heart defects is that the overwhelming majority, so 70% of all cardiac defects are picked up at the booking scan. So at like the general scan, they're picked up, and whoever needs surgery generally knows pretty quickly. So then if you know that like there's something wrong with the fetal heart, you can do one of two things. You can have a termination, you can have a birth at a tertiary center. So if you're out rurally, for example, in Oski, you'll say, oh, maybe you're going to need to go to Monash or something to have your baby. In general, the diagnosis in babies is, is an echo and a Doppler, and you can do a few other things as well. And a couple of other principles is if you want to keep a duct open, you use prostaglandins. And if you want to close a duct, you use indomethacin. Cool. We'll go through it, but sometimes you are going to need to keep the duct open. For example, if you're waiting for surgery, where sometimes you want to close it straight away. Cool. Open, prostaglandins, closing is indomethacin. So NSAIDs. And finally, an innocent heart murmur are all the ones with a sound. So like a symptomatic, a soft flowing murmur, a systolic left sternal edge. Cool. That's really, really common. If someone in general life in peds, if you see a little kid who's got like a little like urti and you listen, they have a murmur, it's probably just a flow murmur, so an innocent murmur. It might come up in exams, but don't forget about it because you get so caught up in like all the fancy schmancy ones, but this is pretty common. Cool. So we'll talk about cyanotic and acyanotic. Has anyone seen this kind of differentiation before? Yeah, kind of. Half of it's new, half of it isn't. Cool. So when we talk about cyanotic things, we're saying that there is not enough oxygenated blood around the body, or there is deoxygenated blood being sent around the body. There's like just not enough oxygen. Yeah, cool, makes sense. Cyanosis, not enough oxygen. And the way you remember it is there's 5 T's and 1 H. Yeah. Acyanotic are the ones that don't have cyanosis, obviously, and they're all the ones that are kind of like the little acronyms, so ASD, VSD, ABSD, PDA, which I think is a pretty easy way to remember them. Cool. So we'll go through them. So the first one is tetralogy of Fallot, not Fallot, apparently it's Fallot. And this is a cyanotic one. It's the first T. And the tetralogy means there's 4 factors about it, right? Four factors. There's pulmonary stenosis. There's right ventricular hypertrophy. There's an overriding aorta, which I think no one really seems to ever know what that is, but I think it just overrides the opening or something like that, whatever. And there's also a VSD. Why do you have a VSD in it as well? So often you have a defect or else the baby would die. So sometimes when you have one congenital heart defect, you also have a VSD is part of it, but it also kind of is a way, like a compensatory method to keep the baby alive. You get something called hypercyanotic spells. So when the baby overexerts themselves, so for example, if they're untreated and it's mild, if they're running, what they'll do is you'll see them classically, they'll run and then they'll go like this, yeah? So they'll squat down and that compresses all the veins of their legs. I think I need to stay near the microphone, but it compresses all the veins of the legs when they squat down. Usually they just fall asleep afterwards. And that's generally not that bad. But if it goes on for more than 15 minutes, that is bad. Why? Because you can get, muscle paralysis. And so they can give IV propranolol or bicarb for muscle acidosis. I think that's a bit too far and you only know that much. The other thing they get is a loud, harsh ejection systolic murmur at the left sternal edge. On the chest x-ray, they're going to have a boot-shaped heart. I don't know how that looks like a boot, but that's the buzzword. And generally this, you do surgery to fix it. Cool? Yeah? So to me, like this is all well and good and you're going to remember it for the next 5 minutes, but I think this is really hard to remember. So I have little mnemonics to remember it. I think I've got a little picture first about what it looks like the right ventricular hypertrophy is over here. There's a VSD over here, etc, etc. Okay, so it goes like this. So who's heard of like the TOF in town? The bar, yeah, cool. Some nods, that's good. Glad everyone's partying enough. So TOF, tetralogy of Fallot, yeah, cool. So one day there's this guy who's covered in blue paint and he's like pissed off drunk and he goes out partying at the TOF, yeah, cool. And he's really drunk and he's causing just an absolute ruckus. And on top of that, he's getting blue paint everywhere. Why has he got blue paint on? Yeah, cool. Speak up. It's okay. Yeah. And so they're really pissed off at him at the TOF and they're like, mate, you got to get out of here. So they boot him out. Yeah? Because they're quite angry. Yeah. Why do they boot him out? Yeah. And not only do they boot him out, they like really hate him because he's got blue paint everywhere. So it's a loud, harsh ejection from the club. Yeah, like a loud, harsh, get out of here. Cool. Why is it loud, harsh ejection? Yeah, it's a loud, harsh ejection. So like, am I getting it? Cool. And you know when people are really drunk and they're outside the club and they've just like got their bottle and just squatting outside drinking? Yeah. Why is he squatting? Tet spells. Cool. Make sense? Cool. Most of the PowerPoint's going to be like this. But like to me, like I made these stories over a year ago and have remembered them in detail until now. So I think that's a sign that they work. And if they don't work, you can just say, no, I don't really mind. Cool. So the next one is TGA, so transposition of the great arteries. Yeah? And what's going on here is that the great artery, so the pulmonary artery and the aorta, just simply switch. Yeah, but just something fucked up and they just went in the wrong direction. Am I allowed to swear in this one? Okay. No one official really watches this, really. I'm employed already. So in order for these guys to survive, they need to have some sort of hole somewhere, yeah? So either a PDA, VSD, ASD, which as you remember are the acyanotic defects. So like they have this problem, but they also need a hole in order to survive. Cool? What happens is these guys present usually at day 2 to 5, which is, you remember, the ductus arteriosus closes within a couple of like hours to days. So generally these guys like present, you know, not immediately, but within a few hours to days. Cool? Usually day 2 to 5. They have no murmur. Yeah, no murmur, but a single loud S2. And on chest x-ray, they look like an egg and a string. And this, I think this actually kind of does look like an egg, but kind of on the side. I don't know what the string is, but can you see that's kind of an egg? Kind of, yeah. Some good Googling found that picture. So how does this, like, how do you diagnose these guys? So this little baby, right, has a defect that is like, it's a, like the 2 arteries have switched. So no matter how much oxygen you give them, they're not going to get better, right? Because it's actual, like it's an anatomical defect. So what happens is you give them 100% oxygen, usually you put them in like an oxygen box, and they don't improve at all. They just don't get better. Yeah? Cool. Which makes sense because no matter what, you're still got a closed loop thing happening. So what do? You give prostaglandin. If you remember, prostaglandin keeps things open. So you give prostaglandin in the meantime to keep things open. And as a quick kind of memory thing, does anyone remember what closes things? Yeah, cool. And then you can do like a balloon atrial septostomy or like an arterial switch procedure, but like whatever, that's what you do later. It's more important that you know which one it is, I think. Okay, you ready for the story for this one? Maybe? So this is like a war between the 2 great arteries, yeah? Oh, also I should say the more like politically incorrect and the more stupid the stories are, the more likely you are to remember them. So sorry if you're offended. It's just, you're gonna remember it. So the 2 arteries are like fighting each other, yeah? Yeah, and they're like, you know, like boxing and they switch positions. Yeah, cool, we got that. And everyone is like it's like a boxing match and everyone's just so excited to see who's going to win. It's just dead silent, right? Because it's no murmur. So everyone's like really eagerly watching to say, oh my God, what's going to happen? So no murmur. Yeah? Cool? And then finally someone wins and they celebrate with like a giant egg fight. Yeah? Why is there an egg fight? Yeah? Cool? We good? Yeah. And that's all. If you can just remember someone has no murmur, it's transposition of great arteries. then you're good. Okay, the other 4 that you kind of need to know for cyanotic, I'm going to really brush over because, truth be told, I don't think you need to know them that well. Like, for example, truncus arteriosus, the aorta and the pulmonary artery are just like one giant vessel. So all these things you really need surge ASAP. For the most part, these are really an issue if someone has had no antenatal screening. Yeah. So, for example, like when you're on ED and someone comes in with a tummy ache and they're female and all of a sudden they're in labor, this is when you're worried because they haven't had like ultrasounds and stuff. But for the most part, I think it's hard enough to remember tough. Hypoplastic left heart as well. Left heart just is crap and can't pump well. That's all I got there. Yeah.
Yeah, you were saying about it, sorry, just going back to TPA.
Yeah.
You did have a murmur, but is it, you must have PA or BSD or ASD.
Yeah.
Would that have a murmur?
That's a really good question. That is a really good question. You know what? Maybe when you do your pediatric training, that might be relevant. I think for now, like if you just think little baby on day 2 has no murmur, that's fine. Yeah, that is a really good question there.
Sorry, just one more question.
Yeah.
So in terms of giving prostaglandin to stop the ear from closing, that like at that stage, you've given oxygen hasn't improved in the cyanotic. Is it a bit late at that stage to stop the closing?
So I think that is a really good question. I think, like, for example, if you're calling in the pediatric cardiac surgeon and they're like running in, I think you'd give it, like, in the meantime, it's not going to hurt.
Yeah.
I mean, that I can think of.
Yeah.
But like all of these things are pretty bad things,
Okay.
you know, yeah.
And can the cyanosis be present pretty much longer?
So generally not with these ones, just because when you think about, so the foramen ovale closes like straight away, but the ductus arteriosus takes a few hours or like a day or 2 to close. So it's only when that closes, you're like, oh my God, this baby's blue.
Okay.
Yeah. No worries. Keep asking away, anything. Oh, should we get to the acyanotic ones? Yeah, I've only really covered 2 of the main cyanotic ones, but those are really the 2 that come up. But this acyanotic comes up a lot. Okay, so the first one is atrial septal defect, so an ASD. And that's from the foramen ovale, which we remember is between the 2 atriums. So it stays open, it becomes an ASD. Yeah, pretty good. It just like never closes. For the most part, these guys are pretty asymptomatic. They might get some recurrent chest infections and it's like, oh, my baby keeps getting sick. And you're like, oh, wait, maybe they have a defect. But for the most part, like they are not as symptomatic. When you listen to their chest, they have an ejection systolic murmur at the upper left sternal edge. But the buzzword that they'll test you on is fixed and widely split second heart sound. Yeah? So a widely split second heart sound, which I think I have a little picture of here. You'll, I guess, want to do like the full, I guess, cardiac screen. And the management is cardiac catheterization with an occlusion device. If there's no treatment, they can get heart failure and arrhythmias later in life. Yep. For the most part, these are less symptomatic. Okay, so this story is pretty inappropriate, but I just remember it as assty, like Homer Simpson's like kiss my assty, because I just imagine like Homer Simpson like fixed and widely split ass cheeks of the second heart sound, and then it's an ejection systolic murmur, like a sound. So you won't forget that. I can assure you that. It came up in our exam and everyone afterwards was like, oh, assty, Karen. And I was like, yeah. So it works. Cool, we'll change this slide now. So VSD is the next one. VSD is the most common heart defect. It is 30% of all heart defects. So if you don't know what the answer is and they're not cyanotic, it's probably just VSD. Yeah? Which is a kind of a good, you know, you've got a pretty good chance. And in real life too, it's like a 1 in 3 chance. So with these guys, a VSD, it's a hole in the ventricle, between the 2 ventricles. Yeah, VSD, ventricular septal defect. If it's small, the smaller the hole, the louder the sound. So you can imagine if you've got pressure going through a really small hole, it will have a lot of resistance, it'll be quite loud. Yeah, makes sense? Whereas if it's larger, it will be a lot softer. Cool. And when we say the size, it's comparing it to the aortic valve. The small ones are usually asymptomatic and they spontaneously close. But the larger ones might need, some more intervention. They can, I guess, cause like recurrent chest infections and also some heart failure and stuff in the future. Cool. I have a kind of stupid story for this, as all my stories are stupid, so I'll stop even saying that. And if these are really, really severe, it can cause Eisenmenger syndrome. Has anyone heard of Eisenmenger syndrome? Yeah, someone who's nodding, do you want to explain it? Yeah.
Usually they have like the left to right shunt initially.
Yeah.
So over time, because the right heart rate starts to get stronger.
Yeah.
And then
Yeah, and then they can get cyanosis. So it starts off an acyanotic, but it can become cyanotic, and it's pretty bad. Cool. So really simple, VSD is versus D, Bigs for dinner. Think of MasterChef. What do? They cook with pans, systolic murmur. Yeah, cool. Like honestly, if you can find out any other way to remember pan-systolic murmur, go for it. But versus dinner is what I got, and it comes up. Cool. And here's just a picture of it as well, just a little hole in the ventricles. So acyanotic AVSD, so it's an atrioventricular septal defect. So it's basically a defect right in the middle of the heart, and really just everything's going everywhere. This is associated with trisomy 21, so Down syndrome. Just on a quick side note, I would learn as much as you can about Down syndrome. It comes up ad infinitum, so worth knowing. But all I got here is that it's associated, so no story with that one. And the last acyanotic one is a PDA, so a patent ductus arteriosus. So if you remember from early on, we got the ductus arteriosus between the pulmonary artery and the aorta, and that just stays open. Cool? Generally speaking, it's associated with premies. So rather than it necessarily being congenital, it's often like because of the prematurity itself is usually the factor here. You get a bounding pulse. Where do you get the bounding pulse? So femoral, yeah? So like, I remember when I was on Paeds, they were like, you should never not put your hand in a baby's nappy. And I was like, that's a really uncomfortable saying to say, but like what it, obviously very inappropriate. But what they mean is you should always check the femoral pulses. But maybe they just need a better saying for that. So always check the femoral pulses. It's really, really relevant. They can develop heart failure in the future. And if it is symptomatic, you can give indomethacin to close it. So an NSAID to close it. And what was the thing that keeps things open? Cool. So you close things with indomethacin. Or, yeah.
Is it that closing both the ductus and the round valve?
I think so. I think so. From what I understand, it's just like anything closing and opening. I could be wrong. But I think so. That is a very good question to ask the pediatrician, just in case I'm wrong. The other thing is they get a continuous machinery-like murmur under the clavicle. Cool. I'll give you my story with PDA. So it's public displays of affection. Yeah, PDA, cool. So young love of like these like gross teenagers all making out. So premies, yeah. Like bounding pulse because they're like so in love that their pulse is bounding. And it's like some gross people like kissing each other's clavicle, just like, continuous murmur under their clavicle. Yeah, pretty gross. Yeah, not going to forget it. Also, that's a picture from WikiHow, how to kiss a girl's neck. So I have a really funny search history at the moment. Yeah, as I typed in holes in babies' hearts, funny meme. Wasn't good. Cool. So coarctation is one that kind of doesn't really fit into anywhere else exactly. So what goes on with this one is that where the ductus arteriosus is, yeah, because it's between the pulmonary artery and the aorta, when it closes, it kind of just constricts the aorta, yeah, and it causes like this coarctation, kind of as we can see in this little picture here. So it constricts. So day one of life, generally a little baby's all totally fine. And day two of life, i.e. when the ductus arteriosus starts to close, the baby just gets real sick. Yeah, so they can get severe heart failure. They have absent femoral pulses. Cool. So what was the other femoral pulses we need to know? Which is? Yeah, cool. So these are absent femoral pulses. They can also get cardiomegaly just from the backflow. And if these, I guess, kids end up growing older, they get a BP difference, or like blood pressure difference in their arms and their legs. They get rib notching, they get really scrawny legs and leg claudication, and usually do a surgical repair. I actually saw someone once in, I guess, a third world country who was on a wheelchair who had tiny, tiny legs and a normal torso. And like, I was wondering if maybe that was coarctation, like untreated. That was pretty interesting. No story with that, but hopefully I'll just remember it. Oh, yeah, I've got, there's also on Wikipedia, if you look up coarctation of the aorta, they've got a really nice video of it. But here, I think it shows really well. You've got the coarctation, and above it, the pressure is really high, and below it, the pressure is really low. So just to really quickly reiterate the buzzwords, we've got the tetralogy of Fellow, which has the boot-shaped heart. So the blue guy who's at the top, who gets booted out, allowed heart ejection, squatting outside. Got the TGA, so like the two arteries fighting against each other. Everyone's dead silent because there's no murmur. There's eggs because everyone has an egg fight afterwards. All the other ones that you don't know that well. And then acyanotic, which is ASD, so fixed split ass cheeks. VSD, so versus dinner, the pansystolic murmur, AVSD, which is trisomy 21, PDA, which is PREMI, please remember PREMI PDA, and coarctation, which has the absent femoral pulses. Cool. And just to reiterate, bounding pulses is PDA, absent is coarctation. Anyone have any other questions until this point? Is this making sense? Do you get a murmur with coarctation? Not that I know of. I just know you get the absent femoral pulses. Does anyone else know the answer to that? I don't think so. No. I don't think so because it's like after the heart. Cool. So I'll quickly brush on Kawasaki's disease because I love talking about it. I don't really know which other PowerPoint it would ever fit into. So this is a systemic vasculitis. And the mnemonic to remember it is warm cream. Yeah? Bit gross, but why not? So warm, a fever for 5 days, that's pretty high. C is cervical lymphadenopathy, so just like big lymph nodes, and also C for conjunctivitis. Get R, a rash, so a polymorphous, it can look like anything. Erythema and edema, and you get this peeling, which is pretty gross, like peeling of the skin. Adenopathy, so again, big lymph nodes, and mucous membranes, again, kind of peel and look a bit gross. You give these guys high-dose aspirin and then low-dose aspirin as well, so the anti-inflammatory and antiplatelet, which is an IVIG, which is intragram, which sounds like Instagram, but it's not, it's intragram, and that will reduce the formation of coronary artery aneurysms in the future. So one kind of like other thing that this could present with is someone comes in like maybe quite young, like in their 30s or something, and has some sort of like coronary artery aneurysms, and you question them more and you're like, when you were really little, did you ever have this weird rash fever thing? And they're like, I totally did. But I don't think it comes out of much. Cool. Are you ready for a quiz? Yeah. So the way I'm going to do this is I'm just going to go around and we're going to keep going around. If you don't know the answer, just say pass. Like, I don't really care if you're wrong. So we'll just tie the back on it and we'll just wind our way. You ready? It shouldn't be too hard. So what's the most common congenital heart defect? Beautiful. 6 split second heart sound. Yeah, RSD. Yeah, brilliant. No murmur? Yeah, TGA. Squat when exercise. Yeah, tetralogy fellow. Egg on string. Yeah, beautiful. Reach part. Yep, bounding pulse. Yeah, so public displays of affection bounding towards their lover. Oh, no pulse. Nailed it. Oh, sorry, trisomy 21 is associated with. Yep. Pansystolic murmur. Yep, versus dinner cooking with a pan. Mnemonic for Kawasaki's. Beautiful. I won't ask you what it stands for. You put someone in an oxygen box and there's no improvement? Yep, cool. Do you feel like you know this? If you're like you're ready for some actual real questions, and not just buzzwords. Okay, we'll keep going as we're going. You're doing really, really well. I'll read them out for the sake of the audience. So an 8-year-old otherwise well boy has a viral illness with a low-grade fever. On exam, a soft systolic murmur is present. His exam is otherwise unremarkable and there's no thrill. It is an innocent murmur. So soft, systolic, otherwise well, all the S's, yeah? A routine examination of a 28-week-old preemie 1 week after birth is noted to have a new murmur. Over the past day, her ventilatory requirements have increased. It is. It's a preemie, so it's a PPA. 3-month-old baby presents the ED with poor weight gain and tachypnea. It's a pansystolic murmur lattice on the left sternal edge with associated parasternal heave. It is. Versus dinner, pansystolic. Getting the hang of this? A little bit? Cool. An infant born at 38 weeks, so term. So if anyone hasn't done gynae obs yet, 40 weeks is term. Weighs 3.6 kilos at birth. At 1 hour of life, he's cyanosed and mildly tachypnic. 100% head box oxygen therapy does not relieve the cyanosis. There are no heart murmurs. Yep, cool. Otherwise, well, 3-year-olds having a checkup is noted to have a soft ejection systolic murmur heard best in the pulmonary area associated with the right parasternal heave. The GP notes that components of the second heart sounds are widely separated during the inspiration and expiration. Yep. Cool. A first-time mother brings in her 5-week-old girl to the ED for the second time as she has noticed that she has rapid breathing while feeding. The clever medical student remembers to check the femoral pulses, but finds they are unable to do so. As the reg is running late, the medical student puts a blood pressure cuff in the arms and legs and notices that the readings are not equal. Yeah. Cool. 8-year-old girl presents with dizziness after an episode of syncope and exertion. You find an ejection systolic murmur at the base radiating to the neck. This one's a little bit tricky, but also not.
Oh, sorry.
You're right. Not quite. Does anyone want to guess for this one? Yeah, so it's aortic valve stenosis. So it's a bit of a tricky one, but also was in a past exam. But like ultimately, if this was an adult, you'd be like, oh, that's classic aortic valve stenosis. But sometimes things just happen in kids as well. Term infant, deeply cyanosed, no murmur at 6 hours. No murmur. Totally silent.
I know this came up.
Four-month-old with poor weight gain, poor feeding, tachypnea, and a loud systolic murmur heard across the entire precordium. Getting slightly trickier. So what's the most common heart defect? So like if you're stuck, what do you go for? Yeah, beautiful. Also, it's a pansystolic, but it's also like a systolic. So when they just say systolic, they haven't said which type. And it's a loud systolic. Also, they're a little bit unwell. They haven't given you any other features. So it's the most common one. Okay, I did not write this question, but it's my favorite one, so I had to put it in there. I'm not even sure where it's from, but I'm going to read it out. You're seeing a 2-year-old boy for the first time. His father denies any past medical or surgical history, but does note that the child's daycare recently sent a note home asking about several episodes, usually after the child does not get what he wants, when he breathes funny and sits in a corner with his knees under his chin for a few minutes. The daycare staffers think that this is self-imposed timeout is a good thing, but they worry about the breathing. One teacher even thought he once looked blue, but decided it was probably because of the finger paints he'd been using. On exam, you identify a right ventricular impulse, a systolic thrill along the left sternal border, and a harsh systolic murmur lattice at the left sternal border. That's a Josh. How good is that question? Yeah, I didn't write it, but it's so good. Cool. is the last question. White cardigan. An infant with Down syndrome is having a routine checkup and a systolic murmurs heard. Nailed it. Cool. Do you feel like you know congenital heart defects now a little bit better? Yeah, cool. Don't be afraid to think of stupid stories to remember things. There's absolutely nothing wrong with it. It got me through the entire way through med school, probably a little bit too much. So you should all do it all the time. We're actually really good for time. Should we do Paeds respiratory? No? Okay. So this is a much smaller section. To me, Paeds respiratory is a really boring topic. Sorry. But like, I think it's one that you can kind of learn the basics really well. And I'll kind of really emphasize the things that come up the most. Okay. So whenever you're thinking about a Paeds respiratory thing, you want to ask a few different questions, well, to yourself really. So firstly, is it a stridor or is it a wheeze? Yeah, what's the difference between a stridor and a wheeze? Yeah, which one's which? Yeah. Then you're thinking about the age. So what they do in exams is they really clearly differentiate the age group. So for example, if a baby that's 6 months old has shortness of breath and a wheeze, do they have asthma? No, absolutely not. So you cannot get asthma until you're 1 year old, technically. Yeah, minimum. So what they'll do is they'll make it quite neat in terms of age. Yeah. You also want to find out if they're vaccinated or unvaccinated. They will generally make that really clear, or else they'll kind of make a really insinuation that they're hippies who eat organic or something like that. But like they'll generally make it clear if they're unvaccinated or vaccinated. If they're unvaccinated, what are you worried about? Yeah. What else? It's one other thing. Yeah, pertussis. Yeah. How old are you when you vaccinate against pertussis? Yeah. So if a baby has pertussis or whooping cough less than 6 months, it's not because they're like it's not like the parents want them to be unvaccinated. That's just what happens. So what you need to do is make sure everyone else is vaccinated. And if they're coughing, you want to find out what type. So it could be a whooping cough, which is whooping cough, or it could be a barking cough, which is cool. So respiratory distress in the newborn, it's quite important to figure out what you're looking for because it's a little bit different from adults. You're looking for tachypnea and apnea. You're looking for things like nasal flaring, yeah, grunting sounds, which are quite obvious, intercostal recession, which this picture kind of creepily does. Head bobbing is a big thing. Central cyanosis. Where do you get central cyanosis? Yeah, so around your mouth. And retraction, so intercostal, suprasternal, costal margin. Yeah, so you're really looking for all those signs. So this very well could be an OSCE on like a doll or something, or they could ask you those things. Cool. So what I've done is I've put all the respiratory stuff by age and by symptom. So with newborns, I think the 4 most commonly tested things, also things you just need to know, is firstly transient tachypnea of the newborn. So this is just when there's not enough, like there's too much fluid left in the lungs. So it's more common if there's a Lusk's presentation or a breech presentation, and it responds well to oxygen. Does anyone listen to Sawbones, the podcast? No one? It's really good. Anyway, the hosts of it, their baby had it because when you, like the theory, well, not the theory, like what happens is like when you have a vaginal delivery, you like squeeze all the fluid out of the baby's lungs. So when you don't have that squeezy thing, then there's fluid left in the lungs. Cool. Generally, that's pretty chilled. It'll just get better. Respiratory distress syndrome, so hyaline membrane disease, is the thing that they probably taught you ad infinitum in first year when they spoke a lot about surfactant and what happens when you don't have enough surfactant. So these are with premies. And if you do a chest x-ray, they've got ground glass appearance. What do you do, for those who've done obs-gynae, or just know, what do you do to prevent this? You've got to say this louder. Steroids. Yep. So when do you give the steroids? Sorry? Yeah, less than 34 weeks. So you want to give steroids, I think it's 2 doses at least 12 hours apart, if my memory is not failing me. before the baby's born. So especially if you need to deliver the baby like early on, you want to get some steroids into that pregnant woman ASAP to try and avoid RDS or hyaline membrane disease, which are unfortunately called the same thing, which is a nuisance. Cool. Does anyone have any questions over there? No? All good? All right. Meconium aspiration. So this is if there's MEC stained liquor. So for people who haven't done OBS yet, what does that mean? Can anyone explain that? Yeah, so the baby pooped in the amniotic fluid. Yeah, and so the amniotic fluid comes out, which is normally quite clear, but it looks like this brownish weird color, and you're like, ooh, the baby was probably stressed. They pooped while they were being born or beforehand, and they could have some meconium, so like their first poo, in their lungs. So you want to treat them, but you also want to give some antibiotics as well. Yep, for obvious reasons. It's poo in their lungs. And finally is congenital pneumonia, which is group B strep. So just out of interest, who's at a hospital in which they swab for GBS? Yeah, where are you? Yeah, also? Angeles, yeah. Who's at a hospital where they don't swab for GBS? Yeah. So I was at Frankston last year and they always swabbed for GBS, and then other people do swab for GBS. It's a really interesting debate, and if you want like a fun conversation topic with your gynecologist, obstetrician, feel free to bring it up. But yeah, essentially, like, you know, you're basically trying to figure out if this baby is at risk for pneumonia or not. There's a few other things as well that you can get in the newborn. So you can get an airway obstruction. So for example, if they've had too much meconium, you know, they could actually be obstructed as well. And there's a few other things, but I think these are the most important things as well. So getting a bit older, more than right now, well, straight after born, is so if they're less than 6 months, i.e. before they're vaccinated, they can get pertussis. So they're paroxysmal coughs. So they are well in between the coughing fits. Yeah. In general, you're thinking about vaccinating the family and also education. So really making sure like the rest of the family is vaccinated and stay safe. Yeah. You often see like when you do GP, like I had so many grandparents who came in, they're like, oh, my granddaughter's pregnant and I need to vaccinate myself. It's like all the time. Bronchiolitis, who's seen a baby with bronch? Yeah, so everyone, like at Frankston Pediatrics, that's literally every single kid I saw. I don't think I saw any peds patient that didn't have bronchiolitis. It's pretty boring. Don't love peds, but generally it's like someone who has an urti and then it becomes a lurty. They have an expiratory wheeze. I guess all wheeze is expiratory, increased respiratory effort. They've got a fever and respiratory crackles. You want to do an MPA. So what does MPA stand for? Yeah, you guys speak really softly, but yes. And it's usually RSV. Have you heard of palivizumab, or however you pronounce it? Has anyone heard of that? So for the most part, bronchiolitis isn't really a big deal. When would you admit a baby with bronchiolitis? Maybe we'll go around to where we were up to. When would you admit a baby with bronchiolitis? Sorry? So really severe work of breathing? Yeah. Why else? Yep. So you're really worried about like failure to thrive and stuff like that? Why else?
Low oxygen saturation.
Cool. Yep, absolutely. I think so.
They've got an underlying disease that you're worried
Yeah, absolutely. So they're high risk that it could get really bad. There's one like other really big reason that's really important in peds. So social reasons. So with any peds thing, like the same kind of goes with croup. If there is a peds little baby and like bronchiolitis, like, yeah, they can be admitted. Like if it's not that bad, they don't have to be. But if, for example, like you don't think the family is able to look after them, it's causing high stress, there is like the carer fatigue, you do not think that the family is able to look after them for social reasons, admit them. Yeah? Like just because it's not a big deal, like things that are not necessarily a big deal can become a big deal if they're not well looked after. Please remember that in any peds OSCE, it's especially in neonatal stuff, it's really, really relevant. You're always looking after the welfare of the kids. So palivizumab, which I can't pronounce that well. So that's if kids are really high risk and they're getting bronchiolitis all the time and you're also nervous it will get worse, you can give this as kind of like, I think it's either a treatment or prophylaxis. I can't exactly remember. But for the most part, I think it costs like a lot of money, like either hundreds or thousands of dollars. And so in general, you don't use it, but if someone's high risk, then you will. So a bit older, you're thinking pneumonia. If they're less than 5 years old, it's usually viral. If they're more than 5 years old, it's more likely to be bacterial, so mycoplasma. They'll come with lethargy, poor feeding, fever. When you listen to them, they'll have crackles as well. And also kind of always bearing in mind that kids don't necessarily present the way that adults do. Yeah, they're more likely to have these vague symptoms, and poor feeding is one of the biggest symptoms. And then asthma, I haven't really touched on asthma and cystic fibrosis because generally speaking, you get a ton of teaching on it and it becomes really boring after a while. So I've left that alone, but in general, you cannot diagnose someone with asthma if they're less than 12 months old. What generally is it? I cannot hear anyone. What? Yeah, like it's more likely to be just bronchiolitis. Cool. So again, bronchitis, you really don't do much. You just kind of look after the kid. Yeah. Has anyone done Paeds and it's just like, you know, hydrate and maintain fluids? Like it's just a really basic management. Cool. So we'll look at the differentials for an acute stridor, which are the, I guess, other really important things. So I think the way to kind of break this down is by sudden, then hours, and then days. Yeah. So a sudden stridor, i.e. the kid is totally fine, and then all of a sudden they have stridor, you're thinking of a foreign object, and especially in toddlers, this is really, really common. Yeah, like the terrible twos, they're playing with things, they choke on it. What's aphonia? Any guesses? Sorry? Yeah, I think they just sound off. I'm pretty sure that's right. Like they don't, like they their voice doesn't work as well. Cool. Anaphylaxis is the other thing. So they're allergic to something. So they get facial and perioral edema. They'll get wheeze and they'll break out in a rash. If there are any doses that you have to know, adrenaline is 0.01 milligrams a kilogram. Yeah, just learn it. It's so important. How do you give adrenaline? Yeah, cool. Always AM. Best way to do it. If you're thinking more hours, so epiglottitis is the one that we are super worried about, and it's also the one that really makes you wonder why anyone doesn't vaccinate their kids. So epiglottitis is caused by Haemophilus influenza B. Do you know when you give the vaccine for that? So I really can't hear anyone. Yeah, beautiful. 246. So these guys will like have a background of being unvaccinated. They will be drooling. So they'll be leaning over and just drooling because they can't swallow anything. There's no cough. They're not coughing. And they're going to have expiratory stridor. So let's say someone like this walks into the ED. What do you do? Like let's say you see this kid straight away. So you're the medical student. You've seen a kid that looks like this, leaning over, drooling, no cough. What's the first thing? Like what's the thing that you want to be really aware of? Sorry? Yep. Don't touch your kid. That's where I'm getting at. You do not touch the kid. And I think the same applies with a lot of kind of Paeds Resp stuff is with all due respect, you're probably just going to make them more agitated unless you're like a really experienced pediatrician. Touching them will only make them more agitated. If they're more agitated, they'll cry more, they will breathe less. You don't want to kill the kid. That would be really uncomfortable and bad for everyone involved, especially the kid. But you're definitely looking at ENT and like anesthetics, and you might need to intubate, but you want to call someone more senior. Cool. That making sense with epiglottitis? Bacterial tracheitis is a super tender trachea. They look really toxic, high fever, and it's normally because of Staph aureus. So classic Staph aureus, you get flu clogs. And then when you're thinking of a few days, so they've had stridor for a couple of days, these are kids with croup. Croup is super common. It's 6 months to 6 years old, but which population normally gets it in that period of time? Yeah, so 1 to 2 years old. They get a barking cough. They get an respiratory stridor. They're febrile. It's a lot worse at night. It's mostly because of the parainfluenza virus, but it can also be RSV. For the most part, like I remember my little sister had croup when she was about 18 months old, and we were like on this like family holiday in this like tiny little farmhouse, and we like took her into the shower in the middle of the night where it was all steamy so she could breathe better as the ambulance came, and it was like real scary. So croup, not that bad until it gets bad generally. But again, like the management is steroids, or like you can give oxygen or adrenaline. But again, when you're thinking of admission, not everyone needs to be admitted for croup. In fact, not that many people do. But if it gets bad and for the same reasons as bronchiolitis, you will admit them. Also, social reasons are a huge component. I was at Frankston Hospital and it was a really big reason to admit people.
So what do you get for
I know you need to like do lots of things. I think you intubate them, and I don't remember what else you give. Does anyone know the answer to that? I just know you need to like refer to someone more senior.
Yeah.
So croup's also called laryngotracheobronchitis. Fun fact, no one calls it that. Cool. So also I think one of the biggest things is the difference between epiglottitis and croup. So for the most part, croup kids, like they're sick, but epiglottitis, they look really toxic, yeah? Have you ever heard like in Paeds, if anyone says when you first want to talk about a kid, you say, are they well, unwell, or sick? Yeah, and I guess the next level would be toxic. Yeah, it's a really good way to start any presentation, any handover. Epiglottitis is a lot more abrupt, whereas croup takes a few days. The fever in epiglottitis is a lot worse. The cough happens in croup, but there's no cough in epiglottitis. Instead, they're not speaking, they're drooling, and they can't swallow. Yep. Does that all make sense so far? So we'll go into a chronic stridor. So we've done sudden, we've done hours, we've done days. So this is a bit longer. So laryngomalacia is a floppy larynx, which usually like they kind of have this stridor sound, but when they sleep, they're totally fine. Usually it just self-resolves at 18 months, but if they are failing to thrive, then you want to do surgery or call someone more senior. What does failure to thrive mean? Anyway? Yeah. Yeah. Whoever's done Paeds, have you seen this kind of like rainbow charts? Yeah, and you kind of track their progress. If they're just not progressing, so if they're kind of stagnating, that's failure to thrive. Like they're not drinking, they're not eating, they're not growing. That's it. On Paeds, if someone's doing well, you just say like #feeding growing, and you're like, yeah, that's all. So subglottal stenosis is if there is a past history of the kid being intubated, like for example, they were preemie, they need intubation, they can have chronic stridor in the future. And macroglossia, so a really big tongue, kids with trisomy 21, that can happen causing stridor as well. So we're doing like really well for time. It's almost finished really. But should we do a quiz as before? Yeah, who are we up to? I think, yep, cool. So a barking cough. Great. A whooping cough is whooping cough, otherwise known as, yes, so it does this. A toddler playing Lego and suddenly becomes short of breath.
Does that mean hormone?
Yep, cool. Great. Drooling, no cough, respiratory stridor, epiglottitis, and what do? Don't touch them, call someone way more senior than you. Oh, epiglottitis is generally caused by? Yeah, and so as a result, which population's getting it? Yeah, absolutely. Cough and fever and worker breathing and crackles. Yeah, pneumonia. Chronic stridor that disappears when you sleep. Yeah, floppy larynx or laryngomalacia. Anaphylaxis give? And do you know the dose? Yeah, beautiful. And how do you give it? Beautiful. Cool. I've got a few more questions for the front row. So a post-term delivery, so big baby with forceps and brownish liquor develops respiratory distress after 9 hours of life. Yeah, mad cows. Oh, and what do you want to give them? Yeah, cool. Antibiotics. A 4-month-old with paroxysmal coughs, and they're well between the coughs. Yep, whooping cough, so pertussis, and they're less than 6 months old. And if they were 12 months old, what are you thinking about the family and their beliefs? Oh, they haven't been vaccinated. Yeah, because less than 6 months is, unvaccinated already. Cool. And also, again, like kid has pertussis, like think about vaccinating all the people around them, like isolate, all that jazz. 32 weeker, which is pretty early, has worker breathing within the first 24 hours of life, and there's a ground glass appearance. Yeah, so RDS or hyaline membrane disease, and what's that caused by? Insufficient surfactant, yeah? So back to first year and all that surfactant stuff, which is making a lot more sense now. So back to the back. It's a 12-year-old girl who has mild intermittent asthma following her bi-weekly basketball games. What do you want to do for her? What advice would you give her? Yeah. So salbutamol before exercise would be good. Cool. And an infant born at term via an elective LUSCS, which is a cesarean section, for anyone who doesn't know that, has a respiratory distress with rapid breathing. There's a wet silhouette of the lungs. Yeah, because like it's not all squeezed out when it gives birth. Cool. I thought I'd very quickly go back to the cardiac things and just like revise the buzzwords. We're good with that? Finishing barely? Cool. You ready? Explain a second heart sound. Yeah, just read them out really loudly because I can't hear very well. Yes. Yeah, cool. That was pretty easy. So I finished like way earlier than I thought that would go, but I thought before I completely end, I thought I'd just talk about some tips for the last few months of the year. I think in general, this is a pretty significant time. So I'm going to like give you older and wiser tips. So first and foremost, I would just stop writing notes. I think they're pretty bloody useless. I think a lot of people write these beautiful summaries of like really thick and they print them out and they bind them and then they never look at them again. Like if you're writing notes, really think of why you're doing it. If you are, I would like just write on a scrap of paper and then put it into something useful. Yeah. I would start doing past exam questions like now. I think they provide you with a few past exam questions. Maybe you have them from other resources, I don't know. But either way, you can get pastmedicine.com is really, really good, or BMJ and examination. I think pastmedicine.com is actually fantastic. It costs like $20, but it's worth it. Anything you don't understand on the EMQs, put into your Quizlet. I've just done a screenshot of my Quizlet to show you how I've done it. So on the right-hand side, I just have like the sentence. And on the left-hand side, I have like one word to describe it. Yeah. Like as you can see, it's just like quick buzzwords. What you do is you can just quickly type it on your phone. It's really fun. It's really easy. To me, it's absolutely useless writing down a piece of paper. ABSD is linked with trisomy 21. But if you have it on a Quizlet and you can play as a little game on your phone, it's A, fun, and B, you're going to remember it more. Yeah, cool. But do the EMQs and do them now. I would start OSCEs ASAP. Grab a buddy that you love and trust and just do OSCEs like once a week. If there's a topic that you don't understand, write each other an OSCE. So for example, you're like, oh my God, I don't understand preeclampsia. Write a preeclampsia OSCE and deliver it to your friend. Yeah? And they'll deliver one to you as well. The Gareth Weston ones, the Obs-Gynae ones, have you heard of those? Yeah. If there is one investment, I keep saying this, if there's another investment you have to do, buy the book or get it from the library and just be that person who just clicks you know, when you just clicking the thing to have it more on the library. Renew, just keep clicking the renew one. I did that this year and never opened a book because it's 5th year. But you should be doing all the ones in the first section. You should be doing them twice. They are unbelievably good OSCEs. I can talk for myself. I think OSCEs were my strong point and it really pushes you up. So be good at the OSCEs. But also don't forget your life and your hobbies and your well-being. Genuinely, a lot of people went really crazy at the end of last year. People get really overwhelmed. They study all the time. A lot of people got sick. Don't do that. You don't need to. You can enjoy it. Me and my friends had a study group. It started to get good weather, and so we sat in the park and we sat in the backyard, and sometimes we just sunbathe and just study together, and then we do mindfulness meditation in between study sessions. I'm dead serious. Make it fun. Make it around dinner. This doesn't need to be a stressful year, and I can assure you if you're having more fun, you will learn more. If you're enjoying yourself, you will learn more. It is really stressful. Don't burn out. Also, your CV, just to be a bit of a wanker for a second, you do have job applications coming up next year. I think Chris Wright told you all that your marks matter the most. Yeah, your marks matter for sure, but don't you getting a really good mark and having absolutely no personal achievements or nothing, I think is a really bad thing for your job application. And everyone just got their jobs recently, and I can assure you having a good CV, doing extracurricular stuff, is just good for the world and good for yourself, but also is good for jobs. So don't feel like, you need to get 2 more points in your Z score and sacrifice the things you love doing, because you should still do them. And finally, just a really shameless plug, if you like all those stories and they actually work and you remember all those buzzwords, I have a podcast. It's called Humorous Hacks. It's on iTunes. It's just casually the #1 medical podcast. So you should all listen to it and download it. I know a few people here already listen to it, but I would be not doing justice to it if I didn't plug it. So yeah, have a plug. There's a lot of 4th year topics on it. Cool, thank you. Finished totally early, but that's good. What to say? Is there any questions? Does anyone have any other questions before I finish on anything?
Yes.
Was it? Oh, good, good.
I love all the stories that you have that.
Oh, I've actually got a podcast episode on this exact topic.
Oh, really?
So if you want to refresh it. Yeah, because did you see everyone knew those buzzwords?
Yeah, because I've gone over piece of cardio so many times and it's not stuck in my head.
No,
But
of
now
course,
I'm
because it's all stupid. You're
Yeah.
which one has this? No, you need stupid ways to remember it.
Yeah, absolutely.
Honestly, if you I've got a half an hour podcast episode. Listen to it. What are you on right now?
GP.
Oh, okay. So you've already done it. Listen to it in a couple of weeks' time, and you'll be like, "Oh, this story is ridiculous."
Yeah.
You'll be sitting in the exam and SD. Oh, excellent. Yeah.
Is it, do you have to buy it? Or?
No, it's free. It's free.
Oh,
Podcast is free, obviously.
Fantastic.
Wonderful.
Thanks.
Thanks
Sorry,
so
I
much.
finished early.
No, that's good.
I fully thought I was